to introduce Chris Morgan as he makes his way to the podium. Chris is a technical director of the immunization for Jhpiego, the Johns Hopkins University affiliate based in Jhpiego's Washington office. He oversees the immunization portfolio in their 30-plus country offices in Africa and Asia. He also supports WHO through advisory work on innovations and the IA 2030 committees, as well as being a regional RITAG, what's it? Regional
I for immunization.
Immunization Technical Advisory Group member.
Thank you. Thank you very much, Joanie. And I don't know how Marcella feels. I'm proud to accept the designation of being leftovers. Well, we all know the curry tastes so much better the next day after it's been in the fridge. Although I suspect that we're all waiting for Leila's group's presentation because sustainable financing is really the bedrock of what we need to do. I'm proud to present here on behalf of another one of the Momentum initiatives. So you've heard already a few presentations from Momentum Integrated Country, MCGL, Momentum Country and Global Leadership, and from Momentum Routine Immunization, Transformation and Equity. This one is Momentum Private Healthcare Delivery, and it's as the name is on the box. So what we are presenting is a review of evidence that we did on behalf of Momentum Private Healthcare Delivery over the last few years. And just to define things, we're talking, when we say private sector, we're talking about all of the non-government healthcare providers, so the ones who do or could provide immunisation services. We're not talking about all the other private sector partners that do things like support advocacy or maybe supply chains or so on. This is immunisation service delivery. But it does include faith-based, non-profit, as well as for-profit under this umbrella of private. And we're really looking at the capacity of this sector to expand reach, and we restricted our evidence review to low and middle income countries. The update, I guess, the polite term is a pragmatic review that really we tried to maximise the evidence available for giving eventually guidance to countries. We leveraged some past systematic reviews, particularly one done by Levin and Katter in 2011, and there was a SAGE working group that considered these issues in about 2016, and before it was presented to SAGE, they commissioned an updated systematic review that covered a whole range of private sector engagement. It was not published, but it's available publicly on the WHO SAGE website. And then to supplement that, we did a formal search of PubMed and then contacted experts to try and see that we hadn't left anything out, Ulla, and came up with an additional 21 publications covering 24 countries. So when you put it all together, there's at least 80 countries with some evidence over the last 25 years, and I'll show a map before that. But first I want to show you the analytic framework that we did for our scoping review. And this framework grew organically through the pandemic period when we were involved in USAID webinars, talking to private sector providers to understand what were the important aspects that would help them engage better in immunisation. And if you look at the middle blue column, we've got the standard considerations, categories of enablers, barriers, risks and challenges. But one of the key points that came out of the webinars is that we should be looking very carefully for any evidence we could find on motivations. You know, why would private providers want to engage in something that really does not make money or is not otherwise easy to sustain if they're providers of clinical services? And we also tried our best to extract as much as we could on how, the process of engagement, how you would engage. That was our results chapters. And then to understand how you might apply them, in our discussion chapters, we use standard health system categories as it is on the right-hand side. So as I said, we found a range of publications when we look at this past 25 years. And the danger when you put a map like this up is that somebody like Ulla Griffiths comes and tells you, hey, you didn't put our paper in there and you haven't got our country in there. So anybody who feels they've been left out, come and see me afterwards, and we won't put you in the publication, but we might do a correction or an addendum afterwards. And it didn't format very well, I'm sorry, but the key point when we looked across this is the private sector contribution varies hugely across these country experiences. And there were a range of different ways that it varied. Sometimes the private providers are the only option, perhaps in fragile or conflict-affected settings. If you include non-profits, faith-based as well as for-profits, sometimes communities have no option but to use them. That includes rural or remote locations. One of the really important evidence updates that we found was on the role of pharmacists, and we've, I guess, all experienced the role of pharmacists in delivering COVID vaccinations and flu vaccinations in some countries. But this systematic review looked right down to the medicine shop level as extenders of services, and that we included in our analysis. Different patterns were seen in some countries. India is a good example, where you have mixed health systems that are segmented. So some families only get their services, whether it's immunization or clinical, in the non-government sector. And again, that differentiates on the basis of their economic capacity. And there are a few countries we found in the study where basically non-government providers of immunization are prohibited because it's felt to be a public sector only service. So I'm not going to go right through this slide, but in terms of our key learning questions, I think for me, one thing that was new in the way that we extracted these data were the trying our best to understand the motivations of private providers to participate in immunisation service delivery. And there are a few places where increased profitability, not only by charging for vaccines, or not even by charging for vaccines, but perhaps getting people in the door and then offering other services for which a charge could be made, or other forms of cross-subsidisation. But what was important was that profitability was not the main, or certainly not the only motivation. Being included in decision making, getting institutional and socio-cultural credibility, or perhaps even fulfilling the organisation's mission by doing immunisation, were as important in many places. And in some providers that were non-government, it gave them a way to improve their own quality and operational capacity by joining in a sort of large and better resourced public health program. The enablers, you can read the list there. I think there's probably fewer surprises in the enablers, but certainly making sure that the non-government providers are mapped and included when doing planning is not a given. Many countries are not currently doing that in the low or middle income world. And making sure that when they are mapped and included, they're also supported with policy, with training, with supplies, if possible with subsidisation of the vaccines. Some of the risks, particularly in mixed health systems, are things like the quality of the service in the non-government sector, if they're offering non-standard schedules or vaccines that are outside the schedule altogether, or if they create a financial barrier to access if there's a service charge that's higher than government facilities, and especially in places where communities don't have another option than the private provider. What we looked for hard and were disappointed not to find much of were these mechanisms of engagement. So we had a few examples of formal government to provider agreements, but not as many as we expected to find. These worked well in places where there was a really clear direct link between the authority to offer immunisation services and some quality standards, supervision, monitoring. And there was one nice example from Indonesia on engagement using professional societies. I'm going to skip this slide because I can see my secundos are ticking over. and go straight to the promising practices under these different categories. And if, say, you're Andy with JSI and looking at advising in Nigeria how to better engage private healthcare facilities for the 22% that use those, this is probably where this research might offer support. Under governance and leadership, making sure that recognition and inclusion is there and that there are formal and supervised agreements. For the financing, pragmatic support that enables a private provider that have to pay their staff and keep the lights on in their clinics to offer the subsidised or free vaccination service that really is the ideal. And under the service delivery, like I said, it starts with the mapping and also not trying to force community care seeking patterns into a mould that they're not already wanting to do. Under the health workforce, really I think for the future pandemic or surge response, mapping the private providers so you can find additional sites and additional staff is going to be critical. But even within the big catch-up and the current programs, they offers one way to extend the reach of government services. Information systems, especially if they're electronic, Marcella, often did not list non-government providers in the database and making it difficult to actually record the immunisations given in the non-government sector. And so inclusion there is obviously a critical enabler, and some recognition of the provision that encourages private providers to go ahead and report into the system. There was some benefits we saw in when private providers, especially networks, for example, networks of private hospitals, had their own logistic and distribution systems in leveraging those for vaccines rather than always using the central supply and logistics. And on community engagement, there are a few examples, particularly in fragile and conflict-affected settings, where having a government label on a service was not always a good thing in terms of acceptability, and leveraging that increased acceptance that some private providers can engage with communities is looking a promising way forward. So in conclusion, I think there is now a significant body of evidence over the past 20 to 25 years. We've got 3 scoping reviews, if you include ours, a systematic review of pharmacists, 80 plus country experiences. There's widespread consensus on the importance of the non-government sector. And there are motivations and enablers that can be leveraged even in places where resources are short. Part of me is a researcher, so I have to say more research is needed, but there is enough evidence already for action. And we see some key opportunities for improved private sector engagement to build more sustainable and resilient programs right now. Mapping by geography and provider type, and we're actually, as you'll see on the next slide, beginning that process in collaboration with WHO African region. To leverage on some of these promising experiences, and for governments that are looking for ways to do it, to provide them with access to it, to prioritise particularly Gavi transition countries, countries that are going to be losing Gavi support in the foreseeable future, seems to be a really important priority group. And pharmacies are doing a lot of vaccination in higher income settings. They clearly could do a lot more in low resource settings. And I've mentioned the future research priorities there. There are some resources available. I'm sorry I don't have those fancy QR codes for you to snapshot, but I assume we'll have access to the slides afterwards. And given that Anne Lindstrand is sitting here, a plea that perhaps there is a way for us to work together on revising that interim guidance document from WHO from 2016, and now that we have a little bit more evidence in hand. So not to put you on the spot or twist your arm, but it feels like that's one way forward. And as I said, we're doing some mapping work in Afro, really with the aim of trying to identify regional, national champions of working with the private sector. So if you have those examples, we would love to hear about them. Okay, so I've got 15 seconds. That gives me time to say thank you very much and also acknowledge USAID.
Thank you so much, Chris. Really valuable work and appreciate you sharing it with the group. I think we should take 5 questions, and I don't promise that we'll get to 5 answers, but let's try with 5 questions. Okay, Dr. Yauba?
Thank you very much, Chris, for that insightful presentation. I just had a couple of comments, at least as we look at the future of immunization and the role of private sectors and how we can actually factor that out into our plans. The first thing is that many countries, particularly in sub-Saharan Africa and also in Southeast Asia, are experiencing rapid urbanization. So we have people migrating from rural areas to urban areas. And then because of that migration, we have the health need, and this is characterized by an unprecedented growth of private health facilities. And in many settings, those private health facilities don't offer vaccination services because governments and Gavi and WHO, they want vaccination to be free in those settings. And most of the times, it's usually like high staff turnover, poor use of pre-qualified equipment, and so on and so forth. So in some cities like Yaoundé and Douala in Cameroon, we have over 90% of facilities are private facilities, right? So those are some of the dynamics that are actually happening, and they will continue to happen as urbanization is happening. And I think there is that need of actually establishing a framework of studying these things and looking at ways of establishing some sort of partnership on how to better engage these private health facilities and deliver immunization.
Thank you for your comment. Dorothy?
Thank you very much for the excellent presentation, very inspiring. And I was just wondering, because most of the time at country level, there is a big challenge for government to coordinate and to align the private sector with the public sector in terms of, making sure that even if I take the example of the information system, for example, it's very difficult to collect the performance information or the activities of the private sector into under the leadership of the government. So there is somehow very interesting, pathways to increase immunization service delivery using non-profit, profit organizations. But the main point is to which extent the government is capable to manage the overall, ensuring also the quality, because even today, Gavi recommendation is to use also the civil society organizations delivering immunization services. And there is a question of, are they equipped, are they skilled, are they capable to deliver high quality services and protecting, safely, I would say, even. So this is a question, maybe you investigated this in your research.
One over here. Oh, please go ahead.
Oh, thank you so much, Joanie from Chai. I think layering on Dr. Yauba's comment, I wanted you to maybe reflect on the mechanisms of engagement, looking at the formal agreements. What are some of the challenges that you've identified with these formal agreements if we're going to institutionalize private sector, private-public sector partnerships? So what are some of the challenges that have been reported in literature that as we now advise governments for these partnerships, to strengthen these partnerships that we can learn from? So if you can reflect on some of those challenges that you have identified in the rich data that you surveyed, that'd be helpful. Thanks.
Thanks, and just one more.
Thank you very much. Just continuing on that front, there are some components of private sector engagement at ground level which actually gets skipped or doesn't reach even the publication level. One of the major components is the healthy or not so healthy competition that happens between private sector and public sector, where the private sector becomes the advocate of an anti-government sector system. Were you able to see any of that reflections in the publications? Because sometimes it becomes my good vaccine versus their crap vaccines. So don't go there, and leading to dropouts and miss out children. That's what we are seeing at the ground level. Were you able to see anything of that in the publication?
Yeah, let's answer.
Thank you. And both your points from Cameroon are really well taken. The urbanization, the internal migration, that really changes the denominators, the catchments, how you reach those is critical. And we did see quite a few papers that showed private sector as more important in some urban poor settings than the public sector. But there are models already. So there are places like Bangladesh where in the urban cities, the majority of vaccinations are given by non-government providers because they are the ones that are most active, and the government had to find a way to empower them and enable them to deliver the services. So I guess we can partner with those linkages. And we also found enough examples of how to make even the for-profit sector be willing to provide them vaccines for free, that we don't need to assume that for-profit providers will always charge for vaccination. There are many examples where they don't need to if they're given other recognition or other reasons to join in. And in terms of, if I can link this to the mechanisms of agreement that you asked about, the ones that seem to be successful were the ones that brought so I'm not talking about the challenges, I'm talking about the success factors, I'm sorry, but the ones that were successful were the ones that brought the private providers to the table and also thought hard about what were the incentives, what were the motivations for them to engage in this work, and factored those things into the agreement while also sticking to some of the public sector priorities that essential vaccines should be provided without financial barriers. And there were there were formal private-public partnership agreements, but there are also ones that were not formalized as a contract, but formalized to the degree that there were benchmarks made about a certain level of provision of service being available for and accessible for supervision visits, and then brought into the quality improvement system. And I think all of those things go to the other question around the coordination. It's really understanding the motivations for providers to be involved and including those in the way the coordination happens, giving them sufficient incentive to actually accurately fill in information systems, accurately comply with schedules. Thank you for the question about competition between public and private. I'm going to indulge in one very quick story. So one of our case studies was from South Africa. Sorry to South Africa, and please take this in the spirit it's offered. But South Africa did an amazing job through the Solidarity Fund in funding providers of COVID vaccination services through an incentive system. So again, that word incentive, where you were incentivized as a provider to deliver a certain number of vaccines per day. Jhpiego, as it happened, was also providing services in car parks and shopping malls and so on under that mechanism. And there were occasional stories where we would find the government clinic would set up their little tent on the next corner and even go out with a megaphone and say, come to our one, don't go to that private one, come to the government clinic. Because the incentive was really well tuned to encourage volume vaccination. So I can't answer the question with the evidence about, we did not find any clear examples of competition apart from that one case study. But the mapping we do in collaboration with the WHO African Regional Office will help us understand where are there communities that only have access to a non-government provider, where are there communities that have access to both government and non-government and therefore have a choice. Thanks very much, Jane.